For those of you who know me, I'm Catherine Donnelly. I'm the Director of the Health Services and Policy Research Institute. And I just want to welcome everyone here today in person and online, and really on behalf of the four hosts. So it's being jointly hosted by the School of Policy Studies, the Center for Studies in Primary Care, the Department of Family Medicine, and History. So we are so excited to have Dr. Meili here today. It is not that common that four different places come together for to be here. So truly we've been able to bring the islands here today. So it's not easy. So following the talk today, I just wanted to let you know there's books out in the lobby. And so they're available and I have a few signing. And there's refreshments in the back, so feel free to grab some. And Dr. Bill Platt will be doing the formal introduction in a few minutes. But before I pass along in the opening, I want to start today by acknowledging those of us here today are situated on the traditional Anishinaabe and Haudenosaunee land. On this beautiful day in fall, in the time of transitions back to school from summer to fall, I want to give thanks for the land and the opportunity to take this time this afternoon to be present. And here today to hear Ryan as he shares his experiences as a politician and as a doctor during those early years of the pandemic, which in some ways seems so long ago, and the lessons for a more just and well society. Saturday will mark the third annual National Day for Youth Reconciliation. The day honors the children who never returned home and the survivors of school, their families, and the community. Reconciliation cannot occur without listening, contemplation, and internal deliberation. As Ryan speaks, I'd like to encourage you to reflect on how the pandemic, how the policies and practices have furthered inequities in our society. It's also an opportunity to consider how politics, how health policy, and health research can be better to help support principles of equity, diversity, and inclusion. With the health sciences.
Thank you very much, Catherine. It is my great pleasure to introduce you to my good friend and colleague, Dr. Ryan Meili. I'm going to tell you a bit about him before I have him come up here and join me. I want to first of all thank Catherine and the planning team for making this happen, and it really is wonderful to see all of these great networks, organizations come together, and thanks to you for coming. For those of you online, hopefully you're hearing us okay. This is really a great opportunity for us to hear from someone who I think is a real leading light in the area of health equity, and somebody that I'm so proud to be able to share with the Queen's community. Dr. Meili is like quite a few people in the room, a family doctor. How many family doctors in the room? Show of hands. 1, 2, it's a half a dozen of us or so. That's wonderful, excellent. He has practiced in most of his career in Saskatchewan. How many from Saskatchewan in the room? Anybody? Not so. Right.
Sorry, Katie, we're just hearing that people aren't hearing so well online, so maybe if you could switch mics with Dr. Meili, I think that was better. Okay. Sorry about that.
Is that better? Let me know if you're hearing. And I can maybe grab Catherine's for later.
I think that one was reported to be not so good either.
Oh, okay. Hopefully this is working. I'll try and hold it up nice and close. So Ryan has practiced in different parts of Saskatchewan, in inner city Saskatoon, and now he is currently working in the northern part of Saskatchewan, particularly on the issue of tuberculosis. So one thing we could ask him about that.
Went and revved up his medical malpractice and made sure his license was up to date. And Ryan jumped into the front lines and worked in a number of different capacities in the clinical care, all the while still being a politician in the legislature. Ryan has written on topics of health equity for a long time, and this is not his first book that he is sharing today. It's in fact his second book, and the best-selling Healthy Society, it was his first book, which really explores social determinants of health in detail. And I'm going to tell you a little story about that in a few minutes. Ryan also started a policy think tank called Upstream, which probably some of you have heard of, and Upstream has now actually merged into the Canadian Centre for Policy Alternatives. I had a great privilege of being able to read an advanced copy of this book. So thank you, Ryan, for letting me do that. It's an incredible book called A Healthy Future, Lessons on the Front Line of a Crisis. And I'm looking forward to asking Ryan about writing that book, about what he hopes we will all learn. And I'm going to get him to come up here and join me now. And I think we are going to sit down together. He's not giving a lecture. This is very typical Ryan style. He wanted to just have an informal conversation. I've got a bunch of questions for him, and about when it feels right, I'm going to stop taking the lead on questions. So get thinking about the kind of questions that you would like to ask, because I want this to be a very interactive time, and I will have lots of questions if you don't have any. But actually, maybe first you can tell us about the really fascinating incident that just happened with you and Catherine and your first book.
Sherry, please let me know if this is coming through. Sounds like it's okay, great. Well, thanks first of all, Catherine and Jane and Sherry and everyone for hosting me today. It's really great to be back at Queen's, and we did have a nice experience today. Catherine and I were just killing a bit of time over by the business school and sat down outside. And at the table across from us was a young woman who was reading my first book. And it was covered with tabs and sticky notes and highlighted through. So of course I bothered her. I went and said, "Hi, I'm Ryan. How do you like the book?" And as an author, seeing that somebody actually did more than buy your book and put it on a shelf is pretty rewarding and motivating. But much more so with this young woman. She told me of her experience growing up in poverty and of her challenges getting into university and how she struggles at times to feel like she fits in, especially in the commerce degree program. And that this book, which talks a lot about healthy society and again into a healthy future, talks a lot about the income gap and the role in that inequity in influencing health outcomes. And she said she recognized herself in one of the particular stories and got goosebumps reading it, which I think gave us goosebumps hearing that back, and just feeling like there's some really important conversations we need to be having in Canada about the influence of those income gaps and inequities on health outcomes. And it's even more encouraging to hear people who've experienced that firsthand talking about how meaningful and important that is to them.
That's pretty exciting. And what I was even more thrilled to hear was that is actually a required textbook for one of our courses.
Yeah, apparently there's.
Does anyone know that? You
Oh, well, there you go. You have someone to thank. Thank you.
Wow, we got a fan here. That's amazing. Thank
Lovely.
you for assigning it. I wish we brought the whole class. Wonderful news. So I want to just backtrack a little bit before we dig into the book, because I do think it's interesting that you and I share a few things in common. But one of them is that both being family doctors, we decided that somehow it made sense in our careers to go from family medicine to politics. Some people would think that doesn't make any sense at all. And I know why it made sense for me, but I'd love to hear you tell us what made you do something like that.
I remember I ran a couple of times false starts or first tries before being elected. And I remember people saying to me, "Ryan, why would you want to do that? You're a family doctor in the trusted professions. You're way up here with the pharmacists and the firemen, and you want to go down to the used car salesman and farmer reps now. Why did you want to do something like that?" And to me, it always comes back to, well, a couple of things. One is that lecture in medical school, in first year medical school, where we were introduced to the concept of social determinants of health. And our prof asked everyone in the class, "So what makes the biggest difference in people's health?" And everybody's saying, well, whether they can get to the doctor, what the wait lists are, things like that. And then she showed us the list, and you see all of us studying so hard to be 12th on the list of what actually makes a difference. And that message that it's income, it's housing, it's education, it's employment. These are the things that really make a difference in the health and well-being of the people we're working to serve. That sort of stuck in the back of my mind as I was training and, doing the late nights of clinical shifts and trying to be good at the clinical side of things, and then get into practice. And in particular, I was working in Northern Saskatchewan with First Nations and Métis populations, and in the inner city in Saskatoon and in Mozambique, and seeing how rewarding that was. I love that work, and I'm happy to be back working in some of those same settings again. I love that somebody comes in, sits down in front of you. I would always say when I was trying to get into medicine that I had this idea that in medicine, your job is to make friends all day. And that sounds terribly naive, I'm sure, especially if some of the docs in the room are feeling burnt out these days. But at the end of the day, that is how I feel about my practice. I get to make friends all day. I get to listen to people's stories, be motivated by them, and help them out in some small way. At the same time, you then turn around and you send them back into the situation that made them sick in the first place. Because that referral or that prescription or that listening ear, it makes a difference in some way, but the underlying issues aren't addressed. And so that's what just kept me thinking about, well, where are those issues addressed? They're addressed in legislatures, they're addressed in parliaments and city halls. And I felt it was important to try and move upstream and be part of where the choices can be made that reduce those inequities, reduce poverty, help create the conditions for people to be healthier. And I wonder, because this is a conversation, so I'm going to ask you questions back. Does that sound close to some of what your thinking was?
I would, you didn't tell me you're going to ask me questions back. But I would say was very similar. I mean, I think that everybody in the room is in some way connected to health. And like you said, you realize it doesn't take very long to realize that those of us who are clinicians can only do so much for the people that are in front of us that we're trying to have an impact on. So there's lots of public health folks in here, and they immediately are further upstream than those of us who are clinicians. But I kept thinking, like, who made these rules that are such bad rules for the way society runs? And I always think that when the rules are bad, you should figure out who made the rule and how you can change the rule. And so you need to eventually get those levers in your hand to say, let's change the rules of society. And that's legislatures largely that do that. It depends. I mean, the rules on campus, there are other ways to be able to change rules. But that's what I want. I wanted to change the way that we had set things up. And as you and I both got to experience, you can do some of that. It's not as easy as it looks on the outside for those of us who are the Sunday afternoon quarterbacks of watching politics. So anyway, let's get back to your book.
Sure.
I really do encourage people, maybe you'll be able to put it on your reading list for next year for your course. I really encourage everybody to read the book and pick up a copy if you can, or think of it as a Christmas present for someone. One of the things that I was stunned by, and you'll probably have the same reaction as you read it, is it reminded me things that I'd forgotten about the pandemic. Like, it was a long time ago and so much happened. And when I was reading through what happened in 2020, I'm like, yeah, we did that. Yeah, we didn't know that. And I kept thinking to myself, how did Ryan remember all this? So I'm curious, and I've never asked you this, like, did you have notes that you were keeping all the way through? Had you thought about writing this book right from the start so that you had that data? How much digging did you have to do to sort of basically reenact the scenes of 2020 and forward?
Yeah. So maybe as a bit of background, the way the book is structured, it's wave by wave. And what did we experience in the first, second, third, fourth, and fifth wave, and digs into different issues that maybe became more prominent in Saskatchewan. For example, the long-term care issue was in the second wave more than it was in Ontario, where really the first wave was where things got really bad in long-term care. And I, of course, look at things across the country, but my eyes were closest to what was happening in Saskatchewan. And I thought of starting to write the book in early 2021. So I was already starting to process that, as it was just such an intense experience. And I guess as a physician and opposition leader, it was almost for somebody who cared about health and politics, it was almost a bit too on the nose, and felt like it was really important to dig into it. But that first book, that idea of the book, was when I was still thinking I'm probably going to be in politics for a while. And so it likely would have been a very different book, the sort of book you see from political leaders. The other guys are bad, we're good. Here's what it would look like if we were in charge. And I think having stepped away from politics also allowed me to have a bit of a broader perspective and dig into things with a little less of that partisan lens in mind. But yeah, had notes along the way, and also I tweeted a lot during that time. So I went back and looked at the Twitter record. What was I saying publicly? And had some help looking through the timelines. And I think that was one of the surprising experiences writing it as well, is going back and saying, oh, I'd completely forgotten about this debate about the timing of teachers getting vaccines or whatever it was. And I was up giving press conferences about it for 5 days in a row. And just there was so much going on that you wind up in this fog, this opaque memory period. And that was part of what I was hoping to do with the book, was, I guess, bring out the flashlight and look at that period with a bit more clarity and try to see what I could and what we could learn from it.
Yeah, it's really effectively done. It took me back and I think that's one of the things I really enjoyed about it. Maybe enjoying is the right word, but it was fascinating to sort of realize all of those things that took place. So thank you for documenting that, because it needs to be known. I also found, to a certain extent, a little bit of triggering and kind of reminding me of the pain of those times. And I wonder what it was like for you as the author, particularly, and as you get into the book, you talk about this really unusual situation you were in, where you were going to the front lines and then you were in the legislature and you were arguing with the government of the day about their approach to policy, and you were bringing the expertise of the front lines there. I mean, first of all, that must have been an incredible experience, and I don't mean necessarily a positive one, but even writing about that must have been a bit traumatic for you. What did that feel like?
This is one of the things I worry a little bit about with this book, is that people are going to say, oh, I've heard of Ryan, I like what he writes, but God, I don't want to think about COVID right now. I've moved on. And I hope that people will look past that and give it a shot, because I think it can actually help us with that pain, to dig into it and try to find some clarity. And for me, yeah, there were some really rough experiences. I think about, my dad had a stroke in April of 2021, and he wound up in the ICU in Regina, completely unrelated to COVID, but that was when we were getting overwhelmed the first time in our ICUs. So I went from visiting him, learning from the nurses who said they were completely at the end of their ropes and they were doubling up patients in the ICU rooms and they'd never seen anything like it. Went directly from there to the legislature to grill the premier about this and try to get him to go visit the place and learn what was really going on, and have that idea rejected, and really no interest from the government in dealing with it in any serious way. And yeah, those were upsetting experiences. At the same time, it felt necessary to be there. It would have felt, I think, worse to be far away and not in a position to be engaging in a meaningful way. But for me, writing this, I have some probably more vulnerable in this book than I'm used to being as someone in the public eye. You shield some of your feelings, but I tell what I really went through. And writing this book, for me, taking the time to go back and dig through and ask what really happened and what should we learn from this. The day that I sent it off to the publisher, it was like this weight lifted off my shoulder, and a very cathartic and therapeutic experience. And I share that because hopefully for people who read through this and it triggers their own memories, but also helps them to process those memories and maybe feel a little bit, well, some lightening of the burden of that past period that was so difficult for us all.
Thank you. Well, again, I do think that it will have that effect on people. beyond that, so I'm just thinking about the links between your first book and the second book and sort of what your hopes were in terms of whether, you intended to highlight, because you did end up highlighting some of the same issues from a different angle.
Mhm.
Was that sort of the core of what you hoped to do, was to use this as a bit of an example of what social determinants of health can do in the context of a pandemic? Or tell me a little bit more about your thinking on motivation.
And maybe best to summarize a little bit the sort of core principle of a healthy society, the idea. What better measure is there for the success of our society than the health and well-being of the people who live here? If government's job is to represent our collective will, and our collective will is to improve the lives of everyone who lives here, how do you tell whether we're doing that well? It's whether people are living long and well. And then when we return to what we were discussing at the beginning of what drives that, that's the social determinants. It's those upstream factors that make the biggest difference. Not only are they what drives health outcomes, they're also what government does. Every one of those determinants, income, education, employment, they all map onto ministries and departments. This is the role of government. You often hear people complaining, oh, the health is taking up so much of the provincial and federal budgets now. Well, it's taking up 100% of the budget. Everything we do is health. It's just whether or not we're actually looking at it that way and making our decisions with the best health outcomes in mind. And so there's that principle of how I think we should be thinking about our political choices. But I also think there's a second principle, which is people care. People care about health. When you look at what the issues are that are number one, federal, provincial elections, healthcare is always up there fighting with the economy for top issue, and the economy is a big driver of health. And I think there's a way to bring people into a better conversation about how we make political decisions by emphasizing that focus on health, and that as our primary goal. And that's where I think we saw something happen for a moment with COVID, where suddenly the scales fell away and health was everything, and everything did come secondary to health. And I'm not suggesting we always want to live in that state, but there was a clarity. And I think by digging into what happened during that time, in ordinary times, we can still learn from how we responded to that, what worked, some of the things that we did really well in response to a major health challenge, but also where we fell short and what we could do better.
Thank you very much for that. And again, I think that you achieved that goal, and that is a beautiful reflection of one of the bittersweet times of the pandemic, realizing that there was a period of awareness. Now, as you go through the waves, you describe how society changed and the public conversation changed. One of the issues that you touch on a bit, and I think it's actually gotten worse since you submitted to your publisher, is issues around disinformation, misinformation, lack of trust. And that's a fascinating and disturbing phenomenon that happened. As you reflected on in writing the book, do you feel like you got a sense of where did that happen? How did that happen? What's the root? Could it have been prevented? How did we end up with this sort of conspiracy theory discourse taking place?
And we experienced this growth of misinformation. The head of the World Health Organization said, we're not just dealing with a pandemic, we're dealing with an infodemic. This was a worldwide phenomenon. Social media and the rabbit holes of YouTube and Facebook have had a huge influence on the growth of misinformation. The presidency of Donald Trump both was fueled by and further fueled that information ecosystem. So a lot of these things are beyond maybe examination of how, as public health or as provincial or federal governments, we responded, but there were opportunities and there were roles that were played. And I think about a couple of things. One is that initial moment, that moment of solidarity where there really was this feeling that we're all in this together, and people were willing to suspend some of their disbelief and differences and engage, banging pots and pans for healthcare workers, all of those things that then switched into healthcare workers getting abused in vaccine clinics and front lines later on in the pandemic by the same people who were supporting them earlier. There were a couple of things that I think we missed. One was the opportunity to work better across political lines. We saw some good examples of that. New Brunswick had a cabinet committee that even included members of parties that didn't have representatives in their legislature. They brought people together. Newfoundland had a similar example. In Saskatchewan, we really pushed for having a table that included opposition and government, but also municipal, First Nations and Métis leaders, business, labor, education, get everybody around the table talking to each other, coming up with our priorities together. And unfortunately, when we said, this was a bit of a unique twist to what happened in Saskatchewan. The provincial government has a fixed set of dates for provincial elections. So we were meant to go to an election in October, but they had a bit of an idea that maybe they could catch us off guard and have an early one. So planning for April election in 2020. That seemed like a pretty bad idea once COVID arrived. Should we send us door to door shaking hands and having rallies? Maybe not. But when I raised that issue in the House, government laughed. They called me Dr. Doom and his caucus of gloom, and said we were completely overreacting and it would be just fine. And unfortunately, that set the stage, and we never got to the place where we collaborated and worked together. I think that's a big piece of the missed opportunity, because having those different voices at the table, different expertise, can help you make decisions that are less politicized and better choices. The other piece was, and we saw different levels of this throughout the pandemic, but the willingness to share both the full extent of our information and the limits of that information. So to trust people with the truth, to tell them the whole story. This is where the virus is. This is where people are dying. This is what we know about transmission. And this is what we don't know yet, and how that information might change. And I feel like people got stuck in this first, it'll be a couple of weeks and things will be fine, and wipe down surfaces, but masks don't work and things like that. It was really hard for people to switch gears because those messages didn't come with, and we might need to tell you something different next week. Or we had in Saskatchewan, for example, a big reopening in April 2020 because things had gone so well in the first wave, but it didn't come with, and here's where we might put the brakes on. Here's how we might have to go back into measures if this doesn't work. And so by giving limited information and saying that what you knew was so fixed, you gave people, because people know, they can tell they're not being told the whole story. And if the official sources aren't giving them the whole story, they go looking somewhere else. And there were lots of people willing to tell stories that weren't true. And I think that grew and grew in that vacuum. And then it got worse as that became popular, and certain governments tied themselves to those folks who are spreading misinformation and said, that's more popular than the truth. Let's go with that. And had politicians across the country repeating things that were firmly false and downright dangerous. And so we can't, people who are in elected roles can't fix all of these things that are going on around the world. It's a much bigger and more complex problem, but there's a role to help try to prevent. I'll take 2 more seconds on this. There's a guy named Tim Caulfield. I'm sure lots of people have heard of him. He's got great work on fighting misinformation. He's got a book called Why is Gwyneth Paltrow Wrong About Everything, which is a wonderful title. And he looks at the Dr. Oz's, et cetera, of the world and all the bunk that they sell. But he talks about pre-bunking, about when you're sharing new information and you know that there are going to be falsehoods spread about it, telling people what they're going to be. And that you might hear that the vaccine's going to make you magnetic. It's not true. And there is something in our minds that goes with the first thing we hear. And so just getting ahead of some of the bad advice and misinformation could be a really important tool to weave into all of our public health communication.
Those are great points. And as you know, you and I have talked a bit before about the lessons that politicians could learn from clinicians. And these are some of the things that I think clinically we learn to do that, right? At the pre-bunk, it's like, you're going to take this medication. Some people are going to tell you that it's not, that you're going to get this side effect. I'm going to tell you what the science says. Politicians haven't figured out how to do that for the most part, to sort of help people understand what the alternative.
And I think we have, fortunately, and not always in our profession, have been comfortable with our ignorance and being willing to say what we don't know. I think people have gotten better at that. That's much more a part of our training, is to be clear about the limitations of our understanding. That is not necessarily the case in politics, and it's seen as something that will be punished. That if you say you don't know everything, you'll be seen as inadequate in that role.
Yeah, excellent point. I want to open it up to the group for questions, and I have a couple I'm saving for later. So I reserve the right to go back to asking questions, but do we have a microphone that we can move around for the sake of the folks online? Please go ahead and introduce yourself as we start for everyone.
Great to see you again, Elaine. Thank you very much for the question and for your work. You've been an advocate for basic income for a long time, for addressing those income inequalities and trying to make sure that there is a floor, that we don't let people fall below. And it's a very sensible policy idea. It makes a lot of sense. I think the CERB experience is mixed, that there would be things that we would be able to look at that were really successful and helpful, and other things that there was backlash against or there were difficulties with. So hopefully there's some study that goes into actually figuring out what worked, what didn't, and what that might mean for if a universal basic income was to come into place. What's the actual appetite among folks in the policy world? I think the study in BC that sort of threw some cold water on the idea makes that a more challenging thing to propose. And the debate that's ongoing between universal basic income versus other universal programs lifting folks up through pharmacare, through dental care and childcare, et cetera, is a valid one that continues to go on. I still think that universal basic income is a program worth exploring and promoting. I don't know if we see on the horizon, and maybe you've got your finger more on the pulse of this, but a jurisdiction that's really willing to experiment with it right now. Are they going down the road still in a serious way? Okay. Yeah, so that'll be an important one to watch. What's one of the things I've often said about Saskatchewan or Manitoba or PEI, we make great labs because we are not that many people. We all kind of know each other, and there are no 6 degrees of separation in a place that horizontal, and it means that you can sometimes move more quickly and be able to respond as you learn.
Great question. Next. Mic does not seem to be working, so I'm going to be like, okay.
Hi, my name is Victor. I'm with Public Health. And one of the things that we learned from the pandemic is that the world is shrinking, that whatever happens in wherever, it will happen in Canada. And how do we promote equity, not just within Canada, but within countries? And that has been really one of the driving forces that I've got into politics. But it is a stumbling block. That's probably why I'm getting out of politics, because I feel that there is no solution, but maybe you can offer a solution for us.
And I expect Jane would have a lot to say about this as well. All of your work with, I will say it wrong, but the Donated Day to HIV and AIDS, all the work that you've done overseas. Often we get into blinders that we only see our own municipal or provincial or national borders, and we don't see beyond them. And as you say very clearly, what happened with COVID happening, emerging in a market halfway across the world and being here within weeks, shows how connected we are. I also think a lot about how much effort we put into making sure that Canadians got vaccinated, but not the rest of the world. And Canada fell short in terms of our response there, as did the pharmaceutical companies who were making the vaccine. So we had this amazing miracle of a novel pathogen sweeping across the world and multiple effective vaccines within a year. And that's incredible. I mean, imagine how different our conversation would be today if that hadn't happened. But we didn't share them around the world the way we should have. And what happened? We got new variants and new variants and new variants. Maybe we would never have gotten into Delta or Omicron or the new ones, Parola, coming today, if we'd actually been sharing those vaccines equitably right from the beginning. So that absolutely underlines the importance of global health equity for us here. Doesn't and shouldn't stop there. We should also care, just because human beings, wherever they live, are human beings and their lives matter. When I think about that, I always think about Paul Farmer and that notion that the idea that some lives are less than others is the root of all that is wrong in the world. And I think we know that in our hearts, and I think most people do, but we get so caught up in our day-to-day and lose track of that core belief that everybody's life is important. And I think the more we come back to that, the more we talk about the fact that equity is a matter of self-preservation, yes, but more importantly, human rights and universal value of human beings, I think we can inspire more people to care. So the follow-up question, while the mic is moving, I wish I had a simple answer, but we have to be in rooms like this and out in the community showing that care and this is where the health professions come in. It's where academic institutions come in by demonstrating social accountability, getting care to where it's needed here and abroad. I think about where I work. I work in the inner city in Saskatoon. I'm so fortunate. I work in the coolest clinic with great docs, nurses, physiotherapists, counselors, visiting specialists, you name it. We offer amazing team care. But we were talking about our region, and I know got the OHT process underway here in Ontario. You're looking at that. Jane talks a lot about how we regionalize public health and make sure that it's available wherever you live. You're able to just show up and know that because you live there, just like you could send your kids to school, you could send yourself to a primary care facility. But when I look at our little region of the 5 neighborhoods that are the inner city of Saskatoon, and for those who don't know Saskatoon, you might think, is there an inner city in a city that small? But unfortunately, reality is we have all of the problems of homelessness and crystal meth and fentanyl that are plaguing every city across Canada. We look at that map and there's just us. There's this one community clinic that cannot do it all. And if I draw the same circumference on the east side of Saskatoon, there's minor emergency clinics, there's minor surgery clinics, there's all these different clinics. All of the facilities are there for the communities that need them the least. So my point being that we need to, in our profession, advocate for making sure that the care is where it's needed here, and that by extension, we work to make sure that countries around the world are able to do the same in their home communities. Sorry for the long answer, and please go ahead.
Thanks for mentioning Paul Farmer. I think his really the illuminating thing about him is really he connects his own story with health equity and policy. And I'm G. Whaley, family medicine assistant professor. So I'm curious. I'm very curious about leadership. In your experience, for both of you as politicians, the skills of consensus building, collaboration, persuasion are not really things my learners are learning. So the easy question is, what did you have to learn? But the harder question for you is, my question is, what did you have to unlearn as a physician to achieve that? And number 2, because this is such a wonderful opportunity. Second question is, I'm very curious, you went back to Northern Saskatchewan to work with Indigenous communities. If you could tell one story of a patient in which you engaged differently, perhaps from a dyadic level, clinic level, community level, politic level, just one story. Great. Thank
Engaging differently, I think for those who have worked with Indigenous communities, for those who have worked in northern areas, there is no way that you can be there and be present and not be changed in the way you practice. And some of those are in ways that, wouldn't make it into any of our lectures or textbooks, but it's making dumber jokes, connecting people with people on humor, the things, actually what I love to do the most. I fly up to northern communities Dene communities in the Athabasca region, which is just below Northwest Territories. And we've had some serious TB outbreaks in the last few years. And I joined that team about a year ago. And we fly up with a X-ray tech, with a machine, a nurse, office assistant, and a doc. And we roll in and we see the clinic folks that we always see, and get set up, and patients start to come in. And because we're far from the IT infrastructure of the South, what happens is the X-ray tech takes the photo of the X-ray and texts it to me, so I've got it on my phone. So I'm sitting there with the patient, I'm doing the history, and then I get a text on my phone and there's their chest X-ray. And at first I just would read it and tell them about it. And then I realized everybody wants to see, even if they had 100 of them, they want to see their chest X-ray. They love it. And especially the little kids. So every time I do the same exact thing, I zoom in and I say, there's your spine, there's your collarbones, there's your heart, here's your lungs. Tell them what I'm looking for if I see anything for TB. And then for the kids, especially the 5 to 8 year olds, you see that little bubble there? That's a fart. And that's maybe an unusual way of interacting with patients, but they love it. And then they're like, wanting to listen to their heart with the stethoscope, and they're ready to come back the next time. And that relationship is formed because I'm not threatening, I'm silly. In terms of the first question, I wondered if you had any thoughts of what you took from clinical care that really was helpful in politics, and what you had to learn to do differently.
The fact that I'm following in Ryan's footsteps. I ended up writing a book this, I've been finishing up this summer, and Ryan gave me a lot of great feedback. And I actually talked about this in the book, but the clinical, taking clinical skills and adapting politics, think that way, that process information that way, and still like attention, like persuasion. I mean, there's nobody that's better at persuasion than nurses, right? Like that is what we do all the time. Like, you're just gonna give you this, or you're not so good that you want. But most of the rest of us, I'm looking at Bob Conn, he's probably pretty good at persuading, dealing with really little ones and their families. Politicians don't know how to do that. And that's why I think we've got into a lot of trouble around vaccines, is that politicians that their specific skills want to have a vaccine. There's no clinician that would ever do that, because the last thing is shame. They're rightfully afraid of. So your clinical skills are completely adaptable. What did I have to unlearn? It was the first time in my life that I went, in the healthcare world, we support one another. I mean, we don't always support one another, but we largely, right? Like the doctor needs to make sure the nurse is successful, that's right. We want each other to do well, because that's the only way it works. It's completely unlike politics. That was a comment. I'm like, there are like 160 people over there that want me to do a terrible job. So they want me to fail at my work. And that was just such a, I've never been in that environment before where people actually wanted me to be awful because that would make them more successful. I never did kind of get over that and realize like, that's weird. And does it really have to be that way? Imagine like whatever party people are with, imagine wanting the people around you to be successful so that we can all be successful as a country or a province or whatever. In my dream world, there'll be a legislature like that.
And I lived the opposite because you were in government and I was in opposition. Exactly. We referred to it as the reverse moral compass of opposition. Whenever anything's going badly, that's great for us. And it's gross. It's a really unpleasant feeling. Ed Broadbent said that opposition is toxic to the soul. And I think he's right. And there was, and you see it not only in the 160 people across the way from you, but the ones beside you and behind you. It's the infighting with your own team. And, you know, we've all had workplaces that weren't great. We've all had colleagues that you kind of wished wouldn't show up to the next meeting. But there is a sense, never at Queen's. Okay, cool. You really are trying to recruit me. That's good. We have those experiences, but there is this idea that there's a common goal and you can always come back to the patient, and it's harder to do that in politics with that adversarial approach. Advantage, I think, coming from health is that you do remember that the first thing we do is take a history. The first thing we look for is a person's story. And when you're trying to do persuasion, there's nothing more helpful than being able to say, I spoke to so-and-so and they had this exact experience. And we learn that as a training, we call it connect, contrast, solve. Here's how we connect to a real person and what the average person out there is thinking of. Here's how we contrast with what's not going right. Here's how we do better. And that just came so natural when you're thinking story, diagnosis, and treatment, right? It's a very good fit. The things that were harder were, yes, the team issue, and also sometimes being frustrated by, there's a sense in medicine that if we appeal to the evidence with our colleagues, we'll come to a common ground. There's a place to look. Is this the right thing? We can check in the literature. We can get closer to consensus. There are key measurables and deliverables that we can say, yeah, that is the right thing to do. And it's much more vague and much more difficult to find that common sense of understanding. And the last thing, and I don't know if this was something you had to deal with, but as a family doctor, I'm a pretty quiet guy. I want you to come sit close and tell me your story and really feel at home. And then they wanted me to boom. They wanted me to give barn burner speeches, and getting loud was probably the hardest thing for me to do.
I think we would all agree that the pandemic lifted a veil on the inequities of our attempts to provide care to our public. And I think many of us seeing that bright light shone on the inadequacies of how we do it or how we did it might have led to more enthusiasm amongst parliaments, governments to actually be bolder in instituting change. And yet you get a sense that we've all become a bit amnestic about it. The veil has fallen back down and we're sort of back to normal. Did we miss a burning platform opportunity? And for you, both of you as physician politicians, one way or the other, how could we have taken, I hate to use the word advantage of a crisis, but certainly built on what we learned, which was pretty graphic, I think, for not just those of us involved, but for every citizen to see how drastically badly we looked after our elderly, how we disenfranchised our kids, how we, all of those things that came up, our marginalized populations who suffered so badly. And we seem to almost wish to forget about it.
I think you've just landed on exactly the core message of this book, is that COVID didn't create these problems. COVID didn't create the problems in our schools or in healthcare or long-term care or in homelessness, but man, did it make it worse and reveal just how cracked and broken the system was, in how many ways we're failing to address both upstream and downstream delivery of care. And what I fear is that the fact that it's painful, the fact that that's a foggy time that's hard to remember, and the apparent inability of governments across the country to do the basic due diligence of having inquiries. If we have a bus crash, we have an inquiry, and that's great. But this was a massive, massive disaster, and we are not looking into it in any serious way. And so I share your fear that there is an opportunity. There's an opportunity to say we've got all this new data and qualitative information on how bad for-profit long-term care is, for example, or how needed the types of primary care reforms that Jane talks about so much are, and how possible they are. I fear that we're missing that opportunity, and the sort of forces of public care are not as ready and able to make those arguments as we need them to be. And I see a flip side to it as well, which is the forces of privatization, those who would seek to say there's a crisis in public care, so let's abandon it for something that'll make us more money, even though we know the evidence shows that won't deliver better care. But they're not going to miss this opportunity. And we see governments like Doug Ford's and Danielle Smith's and others going down that road right now. So I think it's really important that those of us who are maybe a bit traumatized and burnt out shake the cobwebs a little bit and say, hey, this was really a big deal. And there are clear things we can learn. There are clear things we need to fight for and defend, and progress that can be made, but only if we're actually asking the questions and doing the work.
Thank you. I have one last question because I want to make sure people have time to buy a book and get you to sign it. But I would like you to tell people what's next for you. I'll leave it at that. What's next for you?
Sure. So reference Paul Farmer a little bit earlier. It's really inspired by his work with Partners in Health. I don't know if folks have come across Partners in Health before, but if you're at all interested, they're an organization that was started in the early 90s and started in Haiti, now in 12 different countries. He was an infectious disease doctor and anthropologist, wrote an incredible book called Pathologies of Power, and started this rural clinic in Haiti. His organization, he and his colleague Jim Kim had an incredible impact on the treatment of multi-drug resistant tuberculosis, first in Peru and then around the world. And Mountains Beyond Mountains, did you ever read it? Best biography I've ever read, an incredible story of Paul, or there's Bending the Arc on Netflix if you're interested in learning more. As I had this change happening in life, and my wife's a pediatrician, we were like, what do we do now that we suddenly are in control of our own lives and don't have to be going to every constituency dinner across Saskatchewan? And we're thinking, should we go and get a new piece of paper, learn something more, and called up Partners in Health and said maybe we could go work for them. And they seemed to think that was an okay idea. So in December, Meili and I will be leaving to Lesotho, which is a tiny country inside South Africa, working in a multi-drug resistant tuberculosis hospital there, and bringing our two little boys along. Abe and Gus are 6 and 12. So they will have a pretty interesting experience of learning Sesotho and learning life in a different culture. And I know you've got all of that experience from Niger and your experience with your family in Africa. I've always appreciated how you've shared your stories about that time. And I am looking forward to being able to take that notion of, I always talk about the Virchow quote, politics is medicine on a larger scale, but medicine is also politics on a smaller scale, and trying to live my political beliefs in the practice that I do in a new way and a new experience in the months ahead.
Well, we will be following your work in Lesotho very closely. And for those of you who don't haven't read Paul Farmer's works. Sadly, of course, as most of you know, he passed away unexpectedly. Was it 2 years ago now? Yeah. Fantastic worker. And Ryan's a very humble person, and I've never told you this to your face. But I think you're a Canadian Paul Farmer. I've often thought of you in that way. And so this is what it's like to have somebody really phenomenal and inspiring amongst us. So I'm really happy that you're here. And I have 2 ideas for you after Lesotho I would like to right now put into the family options for the future. That you either need to get back into politics because we need people like you there, or you should just come to Queens, because I see leaders from family medicine and pediatrics here. I think we could probably arrange a position in family and a position in peds. So there's a place for you guys in Kingston. And if you don't come back to work with us, please come back to visit often. So.
Well, thank you for the very kind and excessive words of praise, and thank you for your willingness to have this conversation. Thanks everyone for joining. It's such an honor to get to sit with Jane, someone who I look up to in so many ways, and to get to be back in Kingston and have a conversation with you. Thanks a lot.
Thanks, everyone. Thank you. So there are refreshments, there are books. Ryan will stay around for a little while. Ryan has, I should also mention, has a new Substack thing that you should follow and subscribe to. So to read his writings regularly when he goes to Lesotho.